Good morning, good afternoon, good evening, good wherever you are. This is again Dr. Mizan of Mizan Coaching LLC. And in this episode of Medical Legal 101, we're going to go over an extremely important topic, all of you doctors, nurses out there. It's really geared towards my fellow doctors, okay? It's our responsibility. And I think you guys are going to be able to figure out within the first few seconds of this video. All right, so without further ado, we're going to start with a pair of cases that I've actually gotten in my line of work. So case one, an 80-year-old female was admitted directly to the ICU from the ER for diabetic ketoacidosis. She was put on an insulin drip. Eventually, she was hemodynamically stable for discharge, and so she was transferred over to a SNF. A SNF is a skilled nursing facility. So I think I made a video a while back on nursing facilities and how, you know, they're very different. An LTAC, which is a long-term acute care, SNF is a skilled nursing facility. We have ALFs now, which are assisted living facilities, which ironically are not healthcare facilities, which even though they technically they are, but there's no legal liability for an ALF to be providing medical care, which is bonkers to me. So be careful putting your parents and grandparents into these places. Anyway, so she was discharged to a SNF and insulin was not given for a full 24 hours. She was found the next day to be severely hyperglycemic. She had severe vomiting or emesis, and she ended up with something called aspiration pneumonia. Aspiration pneumonia basically means you vomit and then you swallow the vomit. It goes it goes down the wrong tube into the lungs, and it causes profound infection. Usually it leads directly to septic shock. It is then causatively connected to cardiorespiratory or cardiopulmonary arrest. And especially an 80-year-old female, the prognosis is it's very poor, usually death. And that's exactly what happened to this patient of mine. All right, or rather this case of mine. It wasn't my patient, obviously. So case number two, a patient was discharged home on 2 separate prescriptions of Coumadin, which is also known as warfarin. The patient, you know, was just a good patient, went to the pharmacy and just had their medications filled. And again, like, you know, the story is a little bit confusing. I remember when I was reviewing this case, I was like, how could this even have happened? But when I did a deeper dive into the case, it was that the patient, it was an adult male, I think he was in his 60s. He already had some Coumadin from before. And so he went to refill his Coumadin. And so it looked like, you know, he told the pharmacist or something, he already has some of his meds. He just needs this one, he just needs like 1 or 2 specific meds from his hospital discharge. And so the pharmacist, or rather the pharm tech or whatever, right? Like they dispensed an additional different prescription of Coumadin. So I think one was, it doesn't matter. Like one was like 5 milligrams, the other was like 2.5 or something. It doesn't matter. So the patient, again, unbeknownst to the patient, because the patient isn't medically trained, right? So he goes home and guess what? He starts taking all his meds, which he had a lot. He had a ton of comorbidities. And he took 2 separate pills of Coumadin, where really he only needed to take, I think it was whatever, like 5 milligrams or something. But he in total was taking like 7.5 or whatever. It doesn't matter. These numbers are not real. Obviously, I'm not going to give you guys real numbers for my cases to avoid identification. A few days later, he was found dead in bed. And upon autopsy, they found that he had a severe intracranial hemorrhage. Okay, so, you know, I'll give you guys a few seconds. What do you think where do you think the error lies? Like, what do you think the topic of this video is? What went wrong here? Medication reconciliation. So it's the bane of every resident, I believe. So like, I remember when I was in residency, it's like, I hated, you know, I wanted to treat the patient, right? So, and back then, back when I was like a naive, you know, like young buck, I was just very gung-ho and aggressive, and I was like, why is this so important? Of course, like, other doctors have taken care of this, right? Like, we have to trust each other on our medical decisions. Yes, but the thing that I would always teach my interns, and the thing that I was taught actually by amazing attending physicians back in residency, is to own your patient. So what this means is, even if you got a patient, even if a patient was given to you by, a world-class hospitalist, or, it doesn't matter, because now they're your patient, okay? So every single thing, every medication that this human being, this mother or father or brother or sister, is putting into their body is your responsibility, all right? And that's what we signed up as physicians. So don't complain about it. It's part of your job. So when a patient is admitted, you have to do the admission medication reconciliation in your EMR, all right? You have to do it. And then during admission, make sure all the meds are correct. If you have consulting physicians like a nephrologist and neurologist, it is legally their responsibility to put in their own medications. And this goes out to all the specialists out there. If you say, I highly suggest changing Lasix from this to that, it's legally your responsibility to do that, okay? It's not a suggestion to the hospitalist team. A lot of hospital systems basically don't police the specialists, and that's why they feel that they can do that. But legally, and again, I'm a medical legal consulting physician, so I was a family medicine physician. Now I just do pure consulting. I help hospitals, I help patients, I help everyone on this field. So, and my job again is that you don't get sued. That's the point. And all the patients that are injured, my job is to help them seek justice. So, a specialist need to put in your own orders. You can't tell a resident, hey, put in, this whatever for me. You can't do that, okay? And again, it's not smart to do that, because then when we see that, not we, but when medical malpractice attorneys do an audit trail, and they see that why is an IM resident putting in this very specific neurology drug, or this, nephrology drug or something, it doesn't make any sense, right? So then guess what's going to happen? They're going to recruit a fellow neurologist or a nephrologist who's going to say, yes, this neurologist messed up, they should have put in this order themselves. It's very easy to make those arguments, right? Okay. So yeah, so basically, put in your own orders if you're a nephrologist or a specialist or whatever. And then hospitalists, and especially this goes to the residents out there, don't be scared, okay? You're the doctor. So it's even though you're attending, it's under the license of your attending, you guys have to work together. And this is in one of my first videos, attendings have to protect their residents, but residents also have to be smart and protect their attending's license, right? So everyone has to play by the rules. All right, so what is medication reconciliation? Medication reconciliation, again, is when you as the physician who owns your patient looks through every single prescription, reassesses them, and ensures that every single one is correct and necessary for that time. And then when you make discharge instructions, this is something that I learned very well in residency. Literally list it out. Say yes, losartan QAM, this dose for whatever, for hyperlipidemia, or sorry, for blood pressure management, valsartan, for this, whatever, atorvastatin for hyperlipidemia, right? Lispro in the morning, list it out. That way you are CYAing, you're covering your behind, and the next provider is going to have just, explicit instructions on how to manage your patient, who will then become their patient, right? Okay, so yeah, and again, just very, very clear cut. That's the whole point of this channel. We get a ton of these medical legal cases, a ton. And it's when first, it's for case number one, I remember I was looking at it, I was like, wait, why would this patient have aspiration pneumonia? What caused her to vomit up? And then I saw that her blood glucose that morning was insane. I think it was like 690 or something. And so it's like, and then I looked at the MAR, and so it looks like they just didn't receive insulin at all, like during 24 hours. Like basically after discharge from the hospital, she didn't receive any insulin when she should have. She had a very like strict anti-diabetic regimen. And so, you know, and the separate case about like the patient getting 2 different prescriptions of warfarin, that's just egregious, right? Like that's not gonna, like, you know, that just, it was a pure failure of the discharging hospitalist of basically reconciling the reconciling the anticoagulant. And so that, yeah, okay. So these things happen. They happen extremely rarely, but they happen. And the root cause when it's discovered is sometimes MD error, right? Like it's that, you know, sometimes we're stressed, we're tired, we just want to discharge a patient home or to a SNF. But again, like, you know, it's extremely important to do medication reconciliation during admission to make sure all the meds, you know, like talk to the patient's spouse or, you know, next of kin, and make sure that these medications are appropriate to give. A lot of times, and this is something that I remember I would get into like, you know, academic disputes with people with, but, you know, I personally would ensure first with the patients. You know, like a lot of my colleagues would just start medications, and I never did that because you never know, right? Like maybe this list of meds is incorrect. So I would first do the H&P, which is a history and physical with the patient at bedside. And then I would ask them, like, you know, are you taking this medication? Are you taking that? Like, do you know why you're taking this? Like sometimes, and, you know, and a lot of, like very few times I'll admit, like there were some times where the patient was like, you know, I stopped taking that one med like a year ago. I don't know why that's on my list, but, you know, I don't need that. And so as a physician, you should be like, oh, okay, that kind of makes sense. Like there's no reason to be on a PPI, you know, for like 5 years. And then, like, you know, sometimes there are indications, but your job upon admission is to do medication reconciliation, and upon discharge, do a medication reconciliation. And then when if you're discharging a patient to another facility like a SNF, then write discharge instructions. And yeah, so that's really the tips for providers. Like, you know, just make sure it's your patient, okay? So don't, like, you know, it's not about trust. I don't like using the word trust because we're all professionals, but, you know, part of your job is to own the patient. And then when you hand off the patient, like during sign out or upon discharge, it is your standard of care to provide ample instructions for the next provider so that the care is continuous. And again, that's the name of the game, right? Like continuity of care. So again, if you're physically not the doctor with that patient at that point, the continuity of care is spiritually yours, right? Like it's like you're basically teaching the next doctor what to do and what not to do. Yeah, but that's pretty much it for medication reconciliation. Any questions or comments, please leave the comment below. Our team always looks at them. Please subscribe, please share. Add any topics, medical legal topics, any cases that you guys want us to discuss, anything that's happened to your family members. You can DM me, you can direct message me, or you could leave a comment and we will make a video on it and like what you can do as a patient, as a provider. And yeah, and if our team is open to academic lectures or presentations. So if anyone is interested, our email is below. Or rather, our email is in our profile. It's mizancoaching@gmail.com. We go around the nation giving talks. So yeah, and if any patients are out there, any firms, any hospital systems, reach out to us and we're happy to provide some insight into this very, very important but very niche world. Yeah, if anyone wants to go into this world, private message me, email me at any time, and you know, hopefully we can help you out. All right, well, that was the episode on medication reconciliation. I hope it helps. I hope it prevents lawsuits. I hope it protects patients. And yeah, take care. Have a great day. And Eid Mubarak. Like it's actually Eid al-Adha, like tomorrow here in the US, but it's technically right now actually in Saudi Arabia. So Eid al-Adha, Eid Mubarak to everyone. And yeah, take care.